welcome everybody. Welcome to the July Mastermind of the Insiders Group of Dental Codology. Tonight we're thrilled that we have Liz Neis. She nice. Hey, I'm gonna call you nice. Maybe I'll start spelling it right then, Liz. Anyway, Liz Neis. She is off actually in her motorhome, and she's in a storm. So we may hear some noise. And hopefully all the power keeps working. But she's going to talk on oxygen is the key. This is an AGD-paced program in that you can get a 1 CE credit for it. And in order to do that, what you need to do is I need to have a course description. We have the certificate already ready. Please put your full name in the chat box. Okay, that's my written record that you were here. Now, something that's going on, and I actually believe she's here. Lindsay, you're here this time, right, Lynn? I see you. There she is. Terrific. Lindsay Hill is an amazing member that we have, an insider that we have, and she has been working on creating CE questions for all of our masterminds that we've done over the last 2 years. The reason for that is you as insiders, if say you need another hour of CE or you just want to, listen to our masterminds a second time, you can take a 5-question thing and still get a CE certificate. It's also going to be something we're going to start offering to our non-insiders, our non-members. But Lindsay is the one that's been spearheading that, and so thank you, Lindsay, for doing that. It's really been, you're amazing. You're amazing. So, moving forward, what I want to do is I want to review. Now, Patty B, are you here? Patty's not here yet. Okay, here's the problem. I need to have somebody help keep track of who is here or not. How am I going to do this? What's happened to Patty? Hope everything's okay. Anyway, so Angela, are you here yet? Say hi, Angela. Oh, there's Patty. Patty's got my master list, and she marks it on the master list. That's the easiest way to read it. That's okay. It's okay. Angela, are you here yet? Nope, don't see Angela yet. How about Barbie? You're here. Say hi, Barbie. How about Carol Roselle? Are you here? Barbie's here. Carol's not yet. Although some people sometimes call in, so if you call in and you're, I don't see you on the screen, because you have to let me know you're here. Krista? Yes, Connie?
Barbie.
What? Barbie, there she is. Oh, Angela Craig just arrived too. Okay. Connie? No? Diana? Oh, Ellen, I know you're here. Say hi, Ellen.
Hi, Ellen.
Like, you're such a smart aleck. I should have known. I see Cindy Purdy here. Cindy?
Yes, ma'am.
There she is. Thanks for
Happy
joining
to see you. Hi, Liz.
Great to have you. We also, Jean Wentz, are you here yet? No. How about Jennifer Z? Not yet. Jill? Not yet. The other Jill? Not yet. Kendra? Okay. People are going to be calling in late, apparently. Catherine, I see you, though. Say hi,
Yes,
Catherine.
I'm here.
There you are. Great.
I'm here.
Terrific. Kim Jottheim, are you here yet? No. Kim McElwee? Not yet. Lisa, I saw you. Lisa's here.
Yep.
Hi, Lisa. Terrific. Linda Jorgensen? Linda? I think I see Linda on there, but I don't see. Are you talking, Linda?
Hello?
There she is.
Oh, yep, I'm here.
Do you have your glass of wine?
Yes, I do.
You're so good.
It's like only a half a glass, but yes.
Liz, of course, is here. Melissa, say hi, Melissa.
Hey, everyone. Linda, can I
Wonderful
have
to
a
have you.
glass of wine, please?
Can you have my glass of wine? Is that what you said?
Can I share
There
it?
we go. Of course, Lindsay's here. Lindsay Hill, Patty, she's going to be on the bottom of the list. Lindsay, it does help if you put your you know, say yes to these meetings. It just helps us make it go faster.
Okay, I'm here.
That's okay. Michelle Race. Michelle, are you there?
I'm president. I'm president. Yeah, I'm present, and I'm drinking bourbon.
You're drinking. Okay, does that mean you're finally healthy?
Yeah. Well,
You
see,
finally
Linda
shook
told me
off
to
whatever
drink-
got you at ADHA?
Linda told me to drink bourbon and honey and
Started.
And Linda is one of our senior mentors, so I definitely would listen.
yes, I take her advice seriously.
That's right. How about Millie? Michelle, are you here, Michelle Wyndham? Not yet. Nancy Brohan, I see you there. Hi, Nancy.
I'm here, eating my dinner. Hi.
Natalie. No, Natalie yet. How about Paige? Paige here yet? Not yet. Pam? No. Patty Beeson?
I'm here.
Patty Korecki? Renee Johnston? How about Rosalie? Not yet. Russell? Logan? Sandy Rago? Javon, you already said hi. Say hi again.
Hello again.
Hello again. Susan Totten?
I'm here.
There she is. Teresa Shepard? Now, I see Susan Hubbard also on the list. Is there anybody else that called in that I don't see or can't, or don't recognize, so know that you're here? Patty, you want to write you on the list?
I'm trying.
That's it?
Catherine McDonald.
Who?
Oh, that's right. Okay, yes, we had, right, your new participant, right?
What?
Yeah, great. Thank you. Thank you. Okay, let's move forward. First of all, I was already talking about DCC. If you were hearing it, that's the Dental Codologist Consortium. Our work groups are hard at work. I was able to put up our meeting. We had a 2-hour meeting of the whole committee. I was having a hard time getting on YouTube, but it went up today, as well as updating the other meetings that we're having. I'm going to click over right live to the internet. And one of the things about this is we're trying to make this really full and rich with lots of information for you, and it continues to evolve. So as you can see, this is the consortium side. This is where we have the oral cancer group had their first meeting of the second phase, because we're in phase 2 now of working on the coding. There's what we had for all members. And then as you can see, as I scroll down, now these are all available to you at any time if you want to participate and learn more about what's going on actively with the consortium. Again, we're the Green Berets. We're going to get in there. We're going to really make a difference with the codes, and we've got a different strategy this year, and we're really excited about what's going on. I once again want to recognize the liaison and group leaders, Melissa Braca, Patty Korecki, Tasha Bates, Susan Cotton, and Jamie Collins. Those are our 5 work groups. You can see the areas of coding that we're working on: implant maintenance and biofilm management. Remove of provider language. What that's all about is there's parts of CDT that say that only a certain provider can do it. That's what we think needs to be removed. The group from Tasha's group is working on, do we want more Profi codes, or how do we want to deal with it? That's where, Siobhan, the information that you brought forward is so important, that what ADHA did or didn't do. Oral Cancer Evaluation Group, again, that group is really working hard and doing some great building with some other groups, because that's what we're doing with our other coalitions, and that's our second phase. And then the non-therapeutic products, drugs, vaping, that's a real general category, but it's one that we're really excited about. We're really excited about all of them. And look forward to having success next year. Now, at UOR in a week, I'm going to be doing a new product session, and what I'm going to be talking about is something that you're already experiencing. I have 3 parts of my brand of dental codology. First is my speaking and my books, and I think all of you are familiar with that. And of course, everybody that's a insider member gets 40% off on all of the books. There's also the insiders group. Again, we're developing more and more on that, and that's the group that's meeting now. Of course, masterminds are one of the big things we do. And then there's our new insurance navigator method. And that's where we're building a curriculum online to really learn this stuff even more. More about that another time. My number one goal, and I need all the help of every single one of you here, is to build our group and continue to build our insiders group. At Under One Roof, we'll be running a 50% off membership during URR only. Many of you, I have a sneak preview. Patty, I did it. This is in process, and we literally were given a new launch page earlier today. It's really, really new. We've got work to do on it, but there's going to be some new information, new places that you can get support and help with what goes on with the dental codology group. More about that, again, as it's launched. But I couldn't resist. I had to put a picture in. So
yeah, that only came through like at, what, 5 o'clock? That came through at like 5 o'clock?
About. Yeah, about. I want to announce that we have our next mastermind, so you can put this on your calendar. Remember, though, the dates are for the entire year or already on the events section of the Dental Codology website. But the next one is going to be with Kendra Sellers, who has specialized and continues to specialize in billing to medical. I had the opportunity just this past weekend to speak to the Dental Economics Make It More Money meeting. That's not exactly the name. But anyway, about that we've got to stop thinking that we've been making dental diagnosis. There's no such thing as a dental diagnosis. There's only medical diagnosis. Anyway, Kendra will be talking about that more and how the roles that we play in that. The updated way of doing our newsletter is now called the Smart Bulletin. That went out last night. If you didn't get a chance to open it, I suggest that you do. One thing that's exciting is we are having a breakfast at UOR that's sold out in 24 hours. If you didn't get a chance to sign up for it and you will be at UOR, just reach out to me. I'll make sure that you get your name on the list. What also was a new feature last month and will continue is this one, and it's the anecdotes for misinformation on Facebook. If you haven't had a chance to go take a look at it, please, I really am trying to, what Patty and Vicki and a couple other people and any of you can do, if you see something on Facebook that you just go, oh my gosh, I can't believe they're saying that, send it to me. Because I don't, we all are on different pages, but there's so much misinformation out there about it. That's why I call them the anecdotes, the antidote to the misinformation on Facebook. Also, in the second half of the newsletter, we did feature Perio Protect. Perio Protect is one of the companies that sponsor me on a regular basis. The article, and especially after Liz presents and gets us talking here in the mastermind, you're going to want to go and read Dr. Keller's latest research on the composition of microorganisms, especially if you like reading the science. I mean, Dr. Keller is amazing. But there are links in the newsletter that links right over to that article, as well as this case. And Liz, you can probably tell us more about this case, although what they're going to do is that case and its practice will be at the Perio Protect meeting, and that is, there's a link to that as well as a link to the Perio Protect video, again, so you can learn more about what this opportunity is, because for some of you, might have some familiarity with it. You certainly will after Liz talks about it, but there's always more to learn. So if you haven't done it already, make sure you put your full name in the chat box so that you're here, so we know you're here. If you did join us by phone, please just let me know that you were here, text me or something, so that we know that you're here. And without further ado, Miss Liz and I'm going to do it to you anyway, girlfriend. I've been working on a book for, I don't know, I think I've written 4 or 5 other books since she and I first started talking about it. But she is an amazing friend, and she is working, as you can see there, as the group practice liaison and team leader for Perio Protect. So, Miss Liz, without further ado, take it away, girlfriend. And this is like film strips of old. You just tell me when to change the next slide.
Okay. Thank you for joining tonight. I really want to just field a lot of questions for you. I do a lot of trainings for PerioProtect. And so I'm not going to actually do the training. I'm going to give you information and what I find helpful. But if you have a question, I just want you to yell it out, and I'll be happy to answer it. You can type it in the chat box as well. So with that, we'll go to the next. Yep.
Liz, excuse me, this is Patty Beeson. Please, everyone, mute your mic because we can hear the crosstalk. It sounds almost like there's a TV on. And it's really difficult to hear the speaker. Thank you.
Turn those crowns upside down. You got fingerprint info? Oh, no, that is not.
Thank you.
Okay. All right, so you can hear me though, right?
Yes, we can, Liz.
Yes, I'm sorry, but
So, you know, being hygienists, right, we treat our patients, we love our patients, and I always got frustrated working chairside that, you know, I'd work really hard, I'd get it cleaned up, they look great, I'd go over home care, and then they would come back in 3 months and it would look like I never did anything. And that's when I realized a long time ago that we were just treating the symptoms. And for me, and the reason I've come over to PerioProtect is I believe it's the only thing that we have right now that treats disease at the bacterial level. It's very simply a two-step method. There's a prescription tray. The tray is not just made with a suck-down machine. It's made with a gasket seal. You have the seal that goes along the gum line, and you have the edge of the tray. This area is called the vestibular extension, and it varies depending upon pocket depth. And that's how come we need a periodontal charting to make a customized tray for the patient. This tray can deliver the medication as far as 9 millimeters underneath the gum line. So the medication is a broad spectrum antimicrobial of hydrogen peroxide at 1.7%, a very low concentration. That hydrogen peroxide, when held under pressure, and I want you to remember that I just said that, hydrogen peroxide, when held under pressure, breaks apart into oxygen and water. The oxygen is forced to the base of the pocket. And this creates an environment for the bad bacteria to be kept at bay and the good bacteria to populate that pocket. So now the patient maintains a healthy biofilm every day. So we're treating periodontal disease like the chronic wound it is. Chronic wound therapy, something that doesn't heal. They've tried everything. They've debrided it. They've used antibiotics. It's still there. You go to a hyperbaric chamber. They stick you in it. They cover you with potent oxygen. And that's because the right kind of bacteria die. So I tell patients these trays are like mini hyperbaric chambers. They hold oxygen under pressure to kill the bacteria that are causing your infection. These trays last 5 years. You only have to wear them 15 minutes a day. Most people wear them when they're in the shower, driving to work, checking emails, doing a CE online at night. But you only have to wear them 15 minutes, and you do it while you live your life. And the results are phenomenal. The side effects that we get is the teeth slowly whiten over 5 to 6 weeks with virtually no sensitivity. Because at 1.7%, we're not drying out those tubules. But what they're using in offices is 18 to 32%. When you use the trays prior to scaling, it will also break apart any deposits that have already formed, like a piece of chalk out in the rain. It just starts to soften it so that you can remove it much more easily, which is great for us ergonomically, but is really great for our patients. When the patients come back for their perio maintenance visits or their recall visits, if they're using it preventatively, the deposits are very soft and they come off very easily. They have less bleeding, tissue's much healthier, and now they're really a true prophy, or if they're in maintenance, they're perio maintenance. But if you're using it preventatively to protect the periodontium from breaking down in the first place, then they're truly that code 11110. Did I do too many ones there? I might have. But if you're going to also use it with the 4346 code, the gingivitis code, it's a perfect pair, because now not only are you treating the disease for the symptoms you see, you're treating the disease at the cause. And who knows, maybe you could protect the periodontium from breaking down in the first place. So I'd be happy to take any questions, or I could go to the next slide, whatever you want me to do, Patty.
Anybody have any questions at this point? I do. You made a statement right at the beginning. It's the only thing that treats the cause of the disease. Is that what you said? Can you expand on that a little bit more from a scientific point of view?
Okay, it's the only process I know that we're actually treating the cause of the disease, where we're taking that bacterial population and we're changing it. We're creating this microenvironment that's healthy as opposed to unhealthy. And it's maintainable and it's long-term and it's done on a daily basis, because we know how biofilm works, right? As soon as you're done cleaning somebody's teeth, that bacteria starts repopulating that pocket. So if you think of a biofilm like an onion, when you hit it with oxygen, you kill that first layer of bacteria. And when you first start using the product, you may use it 2-3 times a day so that you can hit the regrowth of bacteria. And some people do wear these trays 2 or 3 times a day for a lifetime because their bacteria is that strong. Did I answer your questions with more words than you wanted?
No, I'm the queen of lots of words. It's called, we edit later. Anyway, not really, not this session. I think what I was thinking of is, when you make that statement, there's lots of people, and what's been really popular for a while, although it certainly has dropped off, is using things like Arrestin and all of those other bactericidal type things. Can you explain a little bit about the difference between how, compare it to that?
Okay, so anything else, I guess I forgot a key part of that statement. Thank you, Patty. What I was saying, this is something the patient uses at home. Everything else is done in our office. When you place Arrestin, it's awesome. It's going to be site specific. It's going to, kill the bacteria that are in that pocket. It has to be placed multiple times over multiple visits, but that's done chairside. This is a home care tool that the patient uses, even with a laser. You sterilize that pocket, but the bacteria that grows back is exactly the same. And that's how come we created a 90-day perio maintenance, because we know at 90 days the bacteria becomes strong enough to start the infection process. So we figured if our patients aren't going to do their home care, we're just going to see them closer than 6 months, and we're going to try to keep them healthy even if they don't have the best home care. And how has that worked out for us? So now that the patients have this tool, because let me ask you guys a question. How far does a traditional toothbrush, rinse, or floss reach underneath the gum line if you had to guess? You all know the answer, but I'm going to make you say it anyway. Somebody.
And I will call on you.
1 millimeter. How about 1 millimeter?
It's about 1-2 millimeters. So even if our patients had the best home care in the world, and every hygienist out there, not everyone, but most of those hygienists, they say, I'm going to go over brushing and flossing every time my patient comes in. And gosh darn it, eventually they're going to do what I say so that when they come in here, they're going to be healthy. Or the patient comes in and they swear to us up and down that they're doing all this home care and they still look a mess. They still come in with inflammation. We just assume they're not doing a great job, but they're doing it to the best of their ability. And so this is a tool that puts the power back to the patient. If they use this product every day and leave it in place for at 10 minutes, you're actually killing all the bacteria, but we tell the patient to leave it in place for 15 because that's how long oxygen is being delivered. So they leave this in place, they take a shower, they put it in every day, they're going to love it. Their teeth get whiter, and we also kill all the volatile sulfur compounds so their breath gets fresher. So they love the white teeth and the fresh breath, and those that are in the know, your perio maintenance patients, they love that their gums are healthier. So let's go to the next slide, Patty, so I can show these guys.
Linda, your microphone came on. Linda, did you have a comment?
Yeah, I just was wondering what, if you could talk a little bit about the consistency of the peroxide. I think it's a gel, is it not? And then also the taste of it. Okay, so the consistency is just like a whitening gel. It's a really nice consistency. It's a little gooey because it's viscous, and it also has a really nice minty flavor. The mint that they use is really phenomenal. So each tube of gel has about 45 treatments in it. So a perio maintenance patient will have 2 tubes of gel. So hydrogen peroxide was chosen as a broad spectrum antimicrobial because we make it in our bodies. In fact, you're all exhaling a bunch of it right now
because we produce it in our lungs. We produce it in our livers. We produce it in our white blood cells. Moms even produce it in their breast milk for their babies. And I know that Nancy Brohan knows that. And so this is a very natural product. The only thing that people have had an adverse reaction to, and there's two now because I just heard one from a patient that called in to PerioProtect, but the mint, and it can be compounded without the mint. And now they're making a new compound that does not have the diet saccharin, the sweetener in it, because there are people that are allergic to the sweetening products of the saccharin. So they have lots of new compounds that are coming out for people that are allergic to certain things. And so it's very natural for people. And we're worried about pregnant women and gingivitis and passing those bugs on to their babies. If we can get them healthy during those stages, just think about what we can do for their babies as well.
Isn't it too with that seal that you really don't have very much of that solution in your mouth? It stays where it's supposed to go, right?
Yeah.
Is that part of the
That's
system?
part of
Because
it.
didn't you say something about 9 millimeters? How can you make that claim?
Well, that's what the research has shown, that they've gotten as deep as 9 millimeters. So when the seal is created, it seals up, and it's the pumping action is going to pump that gel down underneath the gum line. And as that patient starts to heal and that tissue starts to shrink, and I think I have pictures of this later on, but this seal may no longer fit. Now the tray is leaking. So you get a new tray, and that'll help maintain it through the edge. But very rarely do patients need a second tray. There are offices that use this for people that just refuse to have any scaling and root planing done at all. Most offices turn patients away. You don't want scaling and root planing? I'm sorry, because everybody's worried about getting sued, and they say, we just can't treat you. Or they code them wrong and they do something they shouldn't in a treatment form just to placate the patient. Well, now you have an option. That patient's not ready to move forward, and they're probably not ready to move forward with treatment because you haven't been able to create the value. They haven't been able to get past their fear, and now you can give them something to help them get their inflammation at least a little bit better controlled, so that their fear level goes down and they move forward with treatment. And so it's not just in the periodontal program, it's in the preventative program, and it's also given to people who have implants and have had a full mouth restoration. They want that gum line to be maintained. They want everything to their frame to be healthy, and this is a great way to help protect all those tissues.
And you brought up implants. Hey, Siobhan, what's your thoughts on this? Siobhan?
Hi. Can you hear me? I have on headphones.
Yeah, we can now. Yeah.
Okay. I don't have any thoughts about this because I have not experienced using it. I know that Catherine, who's on the call, is using this in practice and getting great results. And so that's why I'm here, to learn if this would be something that I can implement into practice. Just looking at the tray, I would wonder how, if you had a patient, in what stage would you give this to your patient who's going through full arch? Because I can't imagine how a tray, obviously would have to be custom fit, but I just can't imagine how this would benefit a patient with that much implant dentistry, the big, implant supported dentures.
So when you place an implant, it's really up in the contour. Patty, go to the next picture, next slide. So the seal of the tray is way up here. So this is where your implants are placed, and they're covered with bone. So when that seal is created, the gel is pumped around all the tooth structures, crowns, fillings, implants, and pushed deep into the pocket. So now that bacteria is healthy bacteria, you're going to get a lot less buildup around that implant, especially, a lot of people have trouble with the cement they can't see on those implants. We never know if we should clean around them or not, or what we should do. And so if you can keep it clean by having a healthy plaque and less deposits filling up there, that's the key. And it works great with implants. In fact, we have many doctors that is just part of their treatment plan. You're getting an implant, then you're getting PerioProtect trays, because it's a big investment. It's hard to lose a tooth. It's hard to have an implant placed, and it's you want it to last forever when patients are paying that kind of money. And I liken it to a fluoride treatment, right? I always told patients clinically, fluoride's like a $35 insurance policy. And if you use this, it can help protect your teeth against decay. And so I guess my question would come back to you. If we can have a healthy plaque rather than a plaque that is going to cause a disease state, what would be a better environment for that implant?
Definitely healthy. And I can see when you are looking at the patient that has a single implant or perhaps a multi-unit bridge, something that more closely, a healthy situation. But just sometimes anatomically, especially when it's a full arch denture, I just can't imagine how.
So if you'd have to take the denture, if they have a denture that comes out, you would take the denture out, and the tray would be made to fit around the implants that are in place. So they would not leave the denture in place.
Okay. My next question is: you said this is hydrogen peroxide.
Mm-hmm.
So
yes.
Are there any long-term studies about the possibility of erosion, especially if you have, exposed threads? There's some literature that is drawing attention to fluoride and causing erosion on an implant surface.
So when hydrogen peroxide came out as a whitening agent, the FDA did extensive research. And I do believe, and you can correct me if I'm wrong, Patty, but it was anything below 3% was considered to be safe and have no contraindications long term. Even sensitivity-wise, the only sensitivity we get with somebody that has a lot of recession is when that pellicle is not forming on the teeth to protect it. And basically the teeth are naked. So you may have to add fluoride. And these are the best fluoride trays ever, because if you think about the fluoride medication being pumped down into the pocket, it's going right to the dentinal tubules. And that fluoride's being delivered right where it needs to. And so there is a therapy if you do 3 fluoride treatments at least an hour apart over a 24-hour period. We'll give you an example of 9 o'clock, 10 o'clock, 11 o'clock. You can actually have 0 sensitivity because we've actually treated the sensitivity at the dentinal tubule level, where traditional fluoride trays just end at the gum line. It does not have that gasket-like seal.
The thing is that the trays are one thing, and the medicaments that we may choose to put in them are individualized. Is that a more accurate statement the way to look at this?
Exactly. Currently, we just have 3 medications that we approve to use in these trays, and that's the fluoride, the hydrogen peroxide gel, and they also use a vibromycin syrup. I thought that would be too much for tonight, but I'm there, so let me talk about it. Vibromycin is a tetracycline product that comes from Pfizer, and it's used in a subclinical dose, meaning you would put a thin ribbon of gel into the tray and a drop in each tray, or 2 drops in each tray. And that is a subclinical dose. And what it does, it will give you this super immune system. And you only would use it for the first 2 weeks to get that immune system boosted up and all this oxygen. You get a whole bunch of inflammation and infection under control. If you use it long term, and we're talking 2+ months over a lifetime, you can actually get bone stabilization, because one of the side effects of using vibromycin syrup at a subclinical dose is it inhibits osteoclastic activity, the cells that break down bone, and promotes the osteoblast. And that stops bone from being lost. And in some cases, we've actually had bone fill in. This isn't a new product. It's been around for 15 years. And it's just taking a very long time for dentistry to embrace it. And so the case you're looking at here is a perio maintenance patient. This is a patient that does electric toothbrush, does a water pick, does an interdental brush, swears she does it every single day. And until they added oxygen therapy or perio protect trays, they were never able to get the inflammation under control, because they've done research that shows that most people brush between 45 to 70 seconds. I can't tell you the last time, and I'm going to be honest here, that I actually did the full 2 minutes on my Sonicare. I maybe get to 3, and that's it. And so if I'm having that hard of a time, what about the rest of the general population? And so even though they're doing their best, and those products can't get 2 millimeters below more than 2 millimeters below the gum line anyway. So what about their 3 millimeter pockets? But if they have a healthy bacteria, that's when the tissue remains healthy. Make sense? And any more questions?
Yeah, you know what I want to do is, Patty B, why don't you tell your story of what you're doing and the reason you're doing it? If anybody's read the Gingivitis Code book, or been to one of my classes in the last couple of years, you've probably seen Patty's case. Patty, start with your impeccable hygiene.
But of course, does it not go without saying, I have impeccable hygiene? You don't want me to start from the beginning.
No, just go through, you know, that you've had surgery and the stabilization and why we're doing, because why you're doing Perio Protect now. It's not because you have an inflammatory condition per se, but you have a long-term condition.
Oh my God, I had a nightmare. I had severe inflammation for quite a while. I had perio surgery in 1985 that ended up with me having 2+ mobility in my bis and 1+ in my molars, and I cried a lot. The tissue on the lingual sloughed off. It was a disaster. And I have lost probably 40% of the bone in my mouth, maybe more in places. So I'm careful about my home care. I go in for routine care, but I know what my prognosis is, and it's not looking pretty. I started with Perio Protect, and I just started with Perio Protect because I want to do something proactively rather than waiting for more inflammation and bone loss. And anything that will help my bone be stabilized, I could only dream to have it improve, but even to keep it stabilized is going to be huge for me, because otherwise I'm looking at implants, and not that far from now, and I don't have that kind of money. And let me also say, Linda, I've tasted this stuff now for a while, and the trays seal it in so well you really don't taste much of anything, because by the time you're done, it's water, basically. And it's a very mild flavor, and you're not putting in so much that you end up with massive amounts of goop in your mouth that you would never want to swallow. It's not like bleaching trays, because I've used those too.
And the trays are super soft and
they're really soft. They're comfortable. I kind of like the squishy. Let me bite down on these. You know, anyway. But for me, and my dentist was like, because he doesn't do Perio Protect, and we had to kind of talk him into it. He looked at me and he said, you know, what do you think you're going to get? And I said, this is proactive. I'm tired of being reactive to the things that have happened in my mouth through no fault of my own. Some of this was hormonal. There were other issues that were going on at the same time I was having the perio surgery, but no one connected those two parts of my body. I said, I'm tired of being reactive. I want to be proactive. I want to do something that's going to make my bone as good as it possibly can be and my tissue as healthy as possible. And that's why I'm doing it.
So you're going to be using the Vibramycin.
Yes.
Right?
Although there's been an interesting twist to that, but yes, I will be using the Vibramycin.
Okay. Cindy, did you have a question? Cindy Purdy? Cindy. Hey, you there, Cindy?
Hey, Patty, Siobhan asked a question. in the chat. She wanted can someone write the 3 recommended medicaments for use in the chart? And there was something special about the Vibromycin. You can't just go out and get liquid Vibromycin any place, Liz.
Right. So they're actually, Pfizer has the brand name, and PerioProtect is shifting to having it compounded at pharmacies locally because there was a back order from Pfizer. So you have to be careful where you get these medications from, because if there is oil in any of the products, it will warp the trays. So the hydrogen peroxide gel does not have any oil. The fluoride, make sure that you're using that doesn't have oil. There's only a few that do. If somebody does oil pulling, you want to make sure that they brush and floss really well, or wear the trays prior to doing the oil pulling, because that will warp the trays. So the medications are Vibromycin syrup to be compounded, and you'll have my email. And then it's Perio gel, and then it's a fluoride. Those are the 3 medications.
Ellen, come on, if you have a question, just ask it. I see something in the chat box there.
Yeah, well, there was a lot of chatting going on. How are these trays made? Typically like a bleaching tray, and how do we make sure that we get that good seal that you're talking about?
I think I have that coming up later on. I have some slides on it, but you can shoot over to them, Patty, if you want to, where the seal is, since that's where we are. So these trays, there's actually a lot of technology that goes into making these trays. This is fine. There's not, you can't just make them with a suck down machine. We utilize a 6-point periodontal charting, really good models, impressions, or scans, and these go through several steps, which is kind of a secret sauce because we hold the patent on these trays. We are the only lab that all the research is done, and the code D5994 was actually given to PerioProtect and is specific for PerioProtect. It's a laboratory process interperipheral seal medicament carrier, and that we're
I gotta stop you. I gotta stop you. It's a coding thing. At this time, this is what's really important to this clarification, because this is a dental codology meeting. The code was brought to the code committee by PerioProtect. At this time, they are the only product that qualifies under it. But the analogy I use, when the code for adjunctive oral cancer screening first came into being, only Visalite was available. And now we have other adjunctive things. At this time, PerioProtect trays are the only ones that qualify under the code, because the code was written specific to what Liz was saying with the patent and also their FDA clearance. Here we go. Had to do it. Thank you.
Yep. No, that's okay. So I forgot the question, but that's okay.
Okay, so I guess my question is then, there's really, really good impressions, models taken, and the perio charting, and then this is sent off to your lab and they fabricate the trays? Is that how this works?
There's 5 labs across the country that are certified to make these trays. And the PerioProtect lab in St. Louis, that's all they do all day long. And they actually offer the best pricing for people to use our lab. But there's 5 labs.
And how long is that turnaround from sending off the impression and the measurements to actually receiving and delivering the trays to the patient?
We can usually get them turned around and made like in 3 or 4 days, but we tell you to plan on 2.5 weeks, because you don't know if you send us impressions on Thursday, depending on the weekend or if it's a holiday, sometimes they get delayed and going back to you the same thing. If you need them quicker than that, you can just let us know. And that's the trays. If people say this to me all the time, if you look at an Invisalign tray or a night guard or a whitening tray, they all stop at the gum line. And even if you go past the gum line, there isn't a seal there. All the gel can just ooze out. When you have this tray on, it's like a Tupperware top. It just holds everything in place so that it doesn't scooch out. And if you do have material that's scooching out, you're just wasting product. You're putting too much in there. I call it the Goldilocks theory, and meaning if you put the trays in and you're tasting a whole lot of mint, you're just putting in too much gel. If you put the trays in and you don't any mint at all, then you're probably not putting enough. It should be the slightest hint of mint. So when you put the gel in, this is what it's going to look like. All the bubbles should be shooting around the tooth structure and they're being pumped underneath the gum line. Go to the next slide. If when you have your tray in, you see this means there's no seal. This means that the gel's just shooting outside the tray. If you have an area where a little bit's shooting out, but most of that gel is staying inside the tray, you're probably in good shape. It's probably just a tight area. But in general, when you have your trays in, this is exactly what it should look like. Now,
can I ask a question? Because Ellen asked a question before, so I have a question related to the population of patients that she has.
Okay.
Ellen, describe your population of patients, because the idea of doing perio charting might be difficult with them, correct?
It may be, but I think in this case, getting a decent impression and model would probably be even more difficult. I work with special needs, and you know, if this could work, this would be a wonderful thing for this population. But it's very, very difficult to get the precise measurements and an impression.
So if getting periodontal charting is an issue, we could make it almost like a maintenance tray, meaning you could say to us, knowing that their pocketing's 5-6 millimeters, tell us, could not perio chart, generalized 5-6 millimeters pocketing, this is the best impression I could get, and we'll work with you. We've made trays for that population. You know, parents bring children, bring their adult children in, or their parents in, and these people want to keep their teeth. That's how come they come in. It's very difficult for them, and it's painful for them to see their loved one going through all this torture. And PerioProtect is a way for them to feel very clean and healthy and fresh, and keep their mouth as healthy as possible for them. And PerioProtect's actually been a really great thing for them. I know Christy McGonaghy was on here, and she's used PerioProtect for a long time and probably can give a lot of information to all of you as well.
So in some cases, almost close to good impressions and information would still possibly work.
Exactly. Okay. We've had people send us 2 or 3 impressions and say, these are the best I could get. Please help me make a really great tray. There's an area on the lab slip. You can send intraoral photos. You can talk to the lab. We are here to help you be successful and make you a superior product.
Okay, great. That's great. Okay, well, thank you.
Cindy Purdy also had a question in the chat box. Are there any studies about using these for oral oncology patients?
So for cancer patients, it's wonderful because they are comfortable. They help add moisture as the hydrogen peroxide breaks down. We usually like to get at least that first step before they start going through their radiation therapy or their oncology treatment. And then sometimes as that tissue starts to shrink and we lose that seal, sometimes they need another tray. Most of the time they don't. They've used fluoride medicaments in this tray as well. I don't have the slide up here of the dead dye, the study we did on the gel, but it actually, the main bug that they used was Streptococcus mutans, and they chose Streptococcus mutans because their slime layer is one of the most difficult ones to break through. And so if it could get through that slime layer, it's also going to help them with decay as well, in my book.
Siobhan, do you have a question?
I have 2 questions. The Vibromycin.
I'm sorry, I'm only going to give you one. No, go for it.
One's a yes and no question. The Vibromycin syrup gel, did you say that was derivative of tetracycline? If so, that actually works really well for treating implantitis. And then secondly, when it comes to impression taken, does the lab accept intraoral scans?
We love intraoral scans. So there's 3 ways that you could send things to PeriProtect. You can take alginate impressions and pour up your own models. You have to use a type 3 stone. The harder stone breaks our equipment. The softer stone doesn't hold up. You can do an intraoral full mouth scan, iTero, all of those scanners, and send everything to us digitally, and we'll pour them up the 3D models. There is an extra fee for that because that resin is very, very expensive. And so just know that. Or you could just send us your polyvinyl impressions. And yes, it's a doxycycline, which is a derivative of tetracycline, and so that's what the fibromycin syrup is.
Great, thank you.
You're welcome.
Any other questions? You want to go back and show some of these cases then, Liz?
We could go through them very quickly. They're just different types of cases that are here. This one's one of my favorites that she's on now. This was a perio maintenance patient. When I was a director of clinical hygiene, this was one of our offices. So I know the doctor and the hygienist. Patient originally had scaling and replaning done in 2014, came every 3 months like clockwork, did everything we asked her to do, and she showed up 3 months later, and she looked like June 8th. And they told her she was going to need scaling and replaning again, and she said, absolutely not, I won't do it. She eventually got trays. 2 weeks of wearing the trays, her inflammation went from needing 4 quadrants of scaling and replaning that she was refusing to 1 quadrant of 1 to 3 teeth and a perio maintenance, and she was ecstatic. And she's referred dozens upon dozens of patients to the practice. And she said, you know, I tell all my friends because we all talk to one another. We all are frustrated because we always come and they tell us our gums aren't healthy and we're doing everything that they said that they wanted us to do. The next case is actually with Lanap. So the top picture is actually at diagnosis. Doctor recommended Lanap. It comes from a periodontist, Dr. Gordon Frazier in Georgia. Patient said, okay, the middle picture is where the patient is at 3 months. This is great results. This is where we're at every 3 months when a patient comes in. We'd clean them up and we'd say, look, I'm going to show you how to use a water pick or an interdental cleaner or super floss. And if you do everything I say, when you come back next time, you're going to look awesome. And we wait 3 months and they usually come back and they look the same way. And so once you add PeriProtect and you treat it with oxygen therapy, you're actually getting the where you want it to get to. And with a laser, the results with PeriProtect as the maintenance piece is amazing, because now they're not only treating when they come into our office, but they're actually changing that bacterial population when they're at home. And then the next one, the next photo, next slide.
I'm getting there. I'm getting there. There we go.
So this is ortho. This is actually Tanya Dunlap's son. And he had trays before ortho, and then he got his trays off. And this is 5 days of using PeriProtect post-ortho. You can also use MI paste in these trays, and they're treating it for the white spots that you see there. So after ortho, the disease process is really ingrained in a lot of these teenagers when they get their braces off. If we can get that disease under control very, very quickly, it's just going to benefit them as well. So a lot of orthodontists are using these post-ortho. And then the next one that I have.
If we can wait for a second, we got a couple questions here. Lindsay asked about the cost. Of course, that's the question she's curious about.
So to make these trays for the private practice, the fee is around $200 for a set of trays. And so most offices will charge anywhere from $600 a tray, $600 a set to $3,000 a set. It's really up to the office that makes it. And now you're all saying, oh, how dare it be so much money? Well, you talk about crowns, you talk about implants, you talk about scaling and replaning. All of this is very expensive. And so, you know, to me, it's a long-term investment. Patty has a great analogy. My analogy is that it's like tires. I spend a lot of money on my tires because I drive a lot and I want them to last me a long time. And I know if I buy them, that it's going to last me a long time. They'll have these trays for 5 years and they're going to wear them every day, 365 days a year for 5+ years. The cost of the tray and the gel over that time frame is about 42 cents a day for a healthier mouth, healthier body, whiter teeth, and fresher breath. Next question.
Hey. Oh, sorry.
Susan Cotton, why don't you just say your question rather than me reading it?
Okay, can you hear me?
Oh,
Okay.
Susan?
Yeah, can you hear me?
Yep.
Right. So Liz, I was curious. I've talked to some head and neck oncology surgeons. They have their head and neck oral cancer patients wearing fluoride trays while they're actually receiving their radiation treatment. Heard of the protect trays being used in that type of situation? So, you know, being proactive and while they're having the treatment.
So, yeah, when you wear the trays every day, for them, what I've heard from offices and from patients is that their mouth is more moist from all of that surgery when they use the gel. And then they also use the fluoride, and they use the fluoride. You can use it every day if you want to, just to leave an hour in between. Do the gel, and then at least an hour later you could do the fluoride, or you could do the 3 times a week, however often you want to do the fluoride. But now you've got a tray that's going to do double duty. It's going to help give them a healthy plaque. It's going to help add a little bit of moisture. It's also going to be a fluoride delivery system as well.
Right. What about wearing these while they're actually receiving a radiation treatment? While they're being radiated.
So what I'm going to tell you, Susan, is I don't think that's an issue at all. I'll have to ask Dr. Keller. I've actually never had that question before, because we're talking head and neck. I don't believe it's an issue. I'll just have to find out from him if he feels like that would change the gel at all.
Okay, great. Thank you.
Terrific. Lindsay, do you have a comment?
Yeah, I'm kind of circling back here to our whole purpose of being here, besides this lovely information, in terms of what we're able to do and prescribe and clinically, because I'm thinking of all these, you know, medicaments we're putting in a tray. It's like, as a hygienist, you know, technically we can't prescribe these. So it just is like going back to all the stuff we're working towards. And this is huge in what we are able to recommend and technically prescribe to the patient without even needing the doctor in there. Am I right about that?
Whoa, love that question, Lindsay. So what I hear you asking is that because of the type of medicaments we're talking about other than fibromycin, is this within the purview or licensing or allowable treatments that a hygienist can do, say under general supervision?
Correct. Basically, yeah.
Right. Okay. Liz, from a perspective of the company, it is a prescription device, though, isn't it? Liz? Oh, no, we didn't lose Liz, did we? Liz? We lost Liz. No, there she is. Liz?
Muted. Somebody muted me.
Oh.
Can you hear me now?
Yeah, we can hear you now. Okay.
Yeah, so it is a prescription tray. The doctor has to sign the lab slip. So it just depends on your practice act. And so at this point in time, we don't have, unless you have a collaborative agreement of some sort, it does have to have a lab slip signed by the dentist.
Okay, let's talk to Cindy. You still there?
Yeah. Can you hear me?
Yeah.
Yeah, we can.
Okay,
what about in Colorado?
I was like, ooh, call me, pick me.
I saw your hand. Go for it, girlfriend.
Let's talk teledentistry.
Mm-hmm.
Oh, yeah.
We can, if you're using teledentistry and have a dentist that you can have a live chat with, you could get their permission immediately and start the procedure if you're not at the same place as the dentist, or if you can have the dentist's permission right away and go for it.
And they can fax or email that that lab slip right to PerioProtect. You send the impressions from where you are along with the periodontal charting, and you're good to go. So yes, teledentistry. I love you, Cindy Purdy. Exactly.
Absolutely, absolutely. And there are states that, by the way, that hygienists do have limited prescriptive authority and can do it anyway. They can prescribe fluoride.
Right,
Not
that's what I was wondering. I know like Maine has a specific prescriptive. Now, Siobhan, do you have another question?
Yeah, no, I was also going to say that there are some states fighting for that as well, with DC being one of them. But I did have a question. Liz, I think I heard you quote a price that offices can suggest between $200 to $3,000. What happens in between if trays become damaged, or if it's the 5 years have expired? Do they have to pay, if you're paying something like $3,000, I hope that there would be some incentive there.
So there are some offices that will have two fees. They'll have their initial set. Let's say an office decides, and this is the average fee, is around $800, okay, for a set of trays, and they charge $800 for their trays. If the patient loses their trays, they have a second set of fees, and let's say they charge $400 for that set, and that's the replacement fee. Because if you have a patient who's using their trays, we know dogs love saliva, right? We have dogs that eat these trays. There are patients that if they have a tooth pulled, their tray is no longer going to fit, so the doctor's going to have to treatment plan for a new upper or lower tray depending on where that is. So there are many offices, some offices just charge them what it's going to cost them to make the trays. So, but if you do that, you need to factor in, materials to take the impression, chair time, and all of that stuff, so you're not losing money as an office. But in general, I'd say the average fee is around $800, $400 a tray. This is covered by flexible spending and health savings accounts. So people get $2,650 a year of use it or lose it money, and you can get it reimbursed from that. We did have Delta Premier come on board, and they are covering it at $350 a tray. So we're getting more and more coverage, but the important part, and Patty's going to love that I remember to say this, is that you send the D5994 code in every time. The more it gets sent in, hopefully the more coverage that PerioProtect will be able to get for those trays.
How we code affects the future of coding.
Huh?
Okay, talk about the case. Liz?
I'm here. Can you hear me?
Go ahead. Yeah, you want to talk about this next case?
Yeah, go to the next slide.
I did. This one or no?
No, the next one.
Okay. That's it. Next one. Did you get the order?
That
one.
I still have just the ortho cases up. That's what I see. Tell me what you see on the
It's not,
screen.
apparently yours isn't going because I'm making everybody else dizzy. My guess.
So which one? So
the
after
one with,
the ortho
Craig,
one. That's okay.
Yeah, this is Craig Buntemeyer.
Okay, Buntmeyer, Dr. Buntmeyer. This is a patient. This patient did not have surgery. That was just with scaling and replaning and tray therapy. This patient refused to have scaling and replaning. They decided to start to earn this patient's trust. He wore the trays 4 times a day for 15 minutes, and this is what he looked like. At week 3, they did a full mouth debridement. They don't have the middle picture in here. The patient was so happy because it didn't hurt so far. He built trust. He said yes to scaling and replaning, and this picture on the left is them 6 months later. And everybody always says to me, well, there's recession there. It's not really recession. That gum is so bulbous, inflamed over that piece of calculus that when they removed it, that's how the tissue healed after scaling and replaning. And the Hobbs case is actually hope for the future. My sister just got diagnosed with Parkinson's disease, and this is her dad. And he was feeling awful. He was losing his teeth. He had a home health caregiver that just could not brush his teeth because he was shaking so bad. And Dr. Hobbs wrote a prescription, and that's 2 weeks of using tray therapy. And her dad was ecstatic because he felt like his mouth was fresher, he felt better as a person, and he felt better about himself. And the home health caregiver was blown away because all she had to do was put the gel in the tray in his mouth and go make the bed or make breakfast or dole out medications. Whatever else she had to do, she could leave those trays in the mouth. And you can leave them in longer than 15 minutes. It's not going to hurt the patient because it's all over. The whole chemical reaction is done in those 15 minutes. And so we don't recommend wearing them at night when you sleep, but you can leave them in longer. And then the next slide was the tray. And so you could see, if you go back on that tray, there's a lot of room around here. So if a dentist does a filling or a crown, this tray will still fit, because usually whatever we cut away is what we put back. Otherwise, you'd have tight contacts. It would feel bulky to the tongue. And so it should fit. Oh, now I'm caught up to you. It just caught up. So the next slide is about biofilm. And so if you go to the next slide, this was a biofilm that was grown by a microbiologist and an endodontist at USC. They paired up to see what bacteria would form in a 6-millimeter pocket over 2 days. So they glued a sterilized polycarbonate carrier into that 6-millimeter pocket and held it in place. And this is what they got 2 days later. It was a complete colonization. The bacteria had created food distribution channels, communication channels, set up a chain of command, and they had created that slime layer. So usually when we see something like that, we think, well, we'll disrupt it, we'll remove it, maybe we'll use some antibiotics, possibly a laser. But you know, they've done studies that have shown that the bacteria that grows back is exactly the same as when you started. And so this is exactly what they also did for that when they put the fibromycin in that pocket as well. We had little tetracycline crystals form on the very tip of that carrier, 6 millimeters down, which meant crevicular fluid wasn't pushing it out of the way. It was staying with the suction seal of this tray, staying at the base of that pocket long enough for those tetracycline crystals to form. I saw you had a different slide up in there that I skipped right over, Patty, if you wanted to go back to it.
No, it's after.
Okay.
It's after.
So hydrogen peroxide, we chose the broad spectrum antimicrobial because it's natural in the body. There isn't a bacteria out there that's resistant to it, and nobody is allergic to it, like antibiotics. So first it's going to debride that slime layer. Once it breaks through that slime layer, it breaks through the cell wall of the bacteria, delivers oxygen, and lyses the bacteria, creates an oxygen-rich environment for the good bacteria to thrive. The gel is actually FDA approved as an oral debriding agent and wound cleanser.
I got Byron Hill's wall.
Yeah, next slide.
I did.
So, you know, I don't know a lot about this case, but I will tell you this patient refuses to brush their teeth. So this is what that comes in looking like every single time. And the hygienist was just throwing up her hands. And finally she said, look, I'd like to get you as healthy as I can. So we're going to start wearing these trays. And you could see how his gums are a little bit healthier and this plaque is actually denatured. And you know, it may not be the best results in the world, but maybe we can keep that inflammation at bay, even if they're not going to brush their teeth or have the best home care. Next slide. And if there's a question, I'll be happy to answer it because I'm just going to keep going. Oh, this is the same patient. The next slide.
Okay, we've got something in the chat in real life. Who's saying this? Krista.
It's Krista. Yeah, I've had real life experience with the product, and I can't say enough about it. It really is a time saver for our hygienists. The scaling and root plane, or rather the perio maintenance patients, left my chair way quicker than my prophy patients because the calculus came off so quickly. And honestly, guys, I mean, we have to watch our ergonomics and how much time we're leaning over our patients. If our appointments can go a little bit quicker, save us time, let us go to the bathroom, less urinary tract infection, ladies.
Guess what? You just led me into exactly where I want to go.
Beautiful. Great segue.
I am doing an experimental phase. You're going to hear more about my health than you want to, but here I go. I started in late 2014, where I was basically asymptomatic other than my asthma flared. When I got to the emergency room, I had polynephritis that had already gone into bacteremia. Since that time, I've had chronic UTIs. Never had a history of it before, but I've had it ever since then. In the subsequent, well, now we're into almost 5 years, 4.5 years, I've had multiple antibiotic therapies. I've had everything you can imagine. I now have 3 more categories of antibiotics that I am allergic to, 2 of which I've anaphylaxed on. I work with an infectious disease doctor, an immunologist, a pulmonary, the whole cadre of specialists. No one that really comes up with anything that's much different than, well, we do antibiotics for a while. Earlier this year, in January of this year, I had IV antibiotics. Had a port put into up in my chest. It's crazy. So along the way, we also did a cystoscopy and found out that my bladder doesn't empty completely. Could that be from not going to the bathroom a half day or a full day half the time when I saw patients? I still do it sometimes when I speak. Part of the reason Patty Beeson travels with me, her #1 job is to make sure I drink a bottle of water an hour when I present, because that's what proper hydration is for me. Because I've become so aware of my urine, because for 9 months I did self-catheterization 5 to 7 times a day. Things seemed to get a little better, and then they weren't again. So at this point in time, what we're doing is because you heard about the mouth and the body being connected. Yeah, look at me, smart mouth here. But I'm doing a combination of PerioProtect twice a day for 20 minutes, as well as self-catheterization twice a day for 20 minutes. We're logging it. I'm doing it as a scientific experiment of my own, if nothing else. But it makes a lot more sense to me as a clinical hygienist to, first of all, not use more medications and more chemicals. And I mean, because, we talk about chemotherapy with cancer, but any medications that we're taking are chemotherapy. And my body's screaming against it. So my belief and my hope and belief is that this is going to make a difference. And if I'll keep you posted. We don't know, and even the people from PerioProtect, we don't know how much it can affect it. But it's one of those things, it ain't going to hurt. And with the chronicity of the UTIs, had to do something different. And that's how much I believe in what we're talking about here.
And there has been exciting advancements for PerioProtect. We've actually been able to lower people's A1C with just adding tray therapy. And we're working with cardiologists and endocrinologists that are recommending they get these trays for their treatment. So that oral systemic link is really vital. And I believe, and PerioProtect believes, that every patient deserves to know what treatments are available to them, no matter how much they cost, and whether we think they can treat it or not. And so we have a great tool to help you talk to your patients, and you can tell them about PerioProtect in 60 seconds or less. So Patty, if you move forward on the slides, I'll walk people through it. And so it's a great slide. Tell me when you're there, because I think I'm on delay.
We're on the perio, we're on actually charting slide.
Okay,
so
go
this is the chart. Go to the next one.
I want you to show the one with the 3 photos on it. It's a laminated sheet. It has 3 photos on it. And you could talk to your patients about what PerioProtect is in 60 seconds or less. And when the patient, you then ask for permission, and then you can make it more detailed, connect it to their risk factors, make it a value. If they're a truck driver, talk to them in truck driver terms. If they're a teacher or a mother or whatever their issue is, or their risk factor, that's once they say, yes, I want to know more, you can go into more detail. So here's how I do it. Go to the next slide, Patty. I say there's a bacteria that's underneath your gum line that's keeping your gums chronically infected. And then you would go to the next slide, which is the toothbrush on the gum line, and you'd say, Even if you had the best home care in the world, there isn't a home care tool out there that gets all the bacteria every single time you brush. So some of that bacteria is left behind, keeping the gums chronically inflamed. We now have this new prescription tray, which is the next slide, which is super comfortable to wear. It forces medication underneath your gum line so the medication can fight the chronic infection you have. It's comfortable to wear. You only have to wear it 15 minutes a day. Most people wear it when they're in the shower, driving to work, exercising, checking email. They'll last you 5 years or more, and they'll slowly whiten your teeth and freshen your breath. Would you like to know more? That's it. And if they say no, you give them a pamphlet. If they say yes, you go into more detail or possibly take the impressions. And it's that simple to talk to your patients about it.
We have another question in the chat box. Kendra, go ahead and say your question. Kendra? Hello, hello, Kendra. All right, what she is asking is, would this be a good proactive approach for implant patients to decrease probable infection? I think we've talked about that a little bit, but go. Want to speak to it again?
Sure. So let's say you have a patient who has periodontal disease that's uncontrolled, and you want to have a really healthy environment. When you wear the trays prior to treatment, you can reduce the amount of bacteria that's in the mouth, so you're not going to introduce a bacteremia into the bloodstream. You're going to have the healthiest area that you can. Place the implant. Patient can still wear the trays. And then when the new crown is placed, you may have to take a new impression for that crown because it's changed. So in those cases, you may want to tell the patient that you may need a second tray as we move along, but I want to get your mouth as healthy as possible, just like in surgery, right? You have to be really healthy to go into surgery or they're not going to operate on you. So let's create an environment in the nastiest part of the body, the mouth, where all the bacteria is. Let's get it really healthy, place the implant. There are many offices that want to place the implant first and then make the trays. Both ways work well, but if you've got a highly compromised patient like Patty in your chair and you're going to place an implant, you want to have healthy stuff going into the we're opening a wound. We're pulling out a tooth. It's an open area where you're placing an implant. If you can have a healthy environment before doing that, it just makes sense to me that it's going to be less problems down the line. But again, it's really, PeriProtect can be placed into any periodontal protocol where you feel comfortable. Some offices use it only in their periodontal protocol, some in their healthy mouth protocol, meaning that gingivitis, treating the periodontium before it breaks down. Because before 4346, we didn't have another code. So now instead of doing a bloody prophy, they're going to utilize PeriProtect to hopefully not have to do a bloody prophy next time.
Right. Kendra has pH in the chat box. She can't apparently unmute, so I'm not sure what that means. Do you have any comments about pH?
So the gel has a 5.5 pH. So if that's the question. But what I want to offer everybody on this training today is I will be more than happy to do a one-on-one training with you. It takes about 50 minutes. If you email me or email Patty and let me know that you want to do it, Patty has sat through the training. I'd be happy to go through that training and train your offices for free on PeriProtect if you want to get the whole group together. So just let me or Patty know.
Terrific. So again, thank you so much for this great discussion. I'm going to leave this up here so you can write down both Liz's, or just take a screenshot of Liz's cell phone as well as her office phone and her email, but you can also go through me if you'd like. We have another comment in the chat box, Liz. I think it's really important. This could be a huge impact, possibly in a hospital setting, to reduce aspiration pneumonia. Mm-hmm. Oh, yes, Susan. Oh, absolutely. Absolutely. All right, everybody have the number. Again, this is a recorded session also, so you can go back and listen to this again in whatever way you want. Again, thank you, Liz. This was awesome. Awesome, great discussion. I know we went a little longer than we usually do. I appreciate everybody that stayed. And if you have any questions, text me, email me, Facebook, Instant Messenger, all those ways. Cindy's also thrown in assisted living, memory care. Yes, I'm glad you see this picture. So I look forward to seeing you all at UOR. If you're going, if you're not going, I look forward to seeing you on one of our masterminds. Again, our next mastermind is on the 13th of August with our wonderful Kendra. The DCC general meeting is on the 25th of August. The place you can always go is to the calendar, the events calendar on the Dental Codology website. Guys, we're not just doing this for our health and for CE. We're shaping the future by the choices that we make. So thank you so much for all being here. And I wish all of you a good night.
Thank you, everybody.
Thank you, Patty.
Thank you.
Good night.
Thanks, Liz.